it's about 5 minutes past the hour, so I think we should get started. So welcome everyone to Cardiology Rounds. Today, Andrew Shaw, who is a second year cardiology resident, PGY5, will be talking about type 2 myocardial infarction. The title of his presentation is In Demand, Type 2 Myocardial Infarction and Cardiovascular Risk. Thanks, Andrew.
Awesome. Thanks so much. So the title of my presentation has gone a few different revisions, but essentially what I'd like to talk to you about today is type 2 MI, myocardial injury, and cardiovascular risk. No disclosures whatsoever or conflicts of interest. As Dr. Yan pointed out, I'm one of the PGY5 cardiology residents here in Toronto. I have no real disclosures or anything to make. The only thing that I will say is that kind of what inspired me to come up with this topic and to read through the existing literature on this topic is just how much it reflects our everyday clinical practice as cardiology residents. Many consults we see in the hospital overnight for troponin elevations in patients with other medical illnesses, and just trying to understand how we can best optimize and best treat and give the best advice in these kinds of scenarios. And that was kind of the impetus for this round's presentation. So the objectives are to review the definition, epidemiology, and outcomes of MI and type 2 MI, to recognize the nuances and pitfalls in the diagnosis of type 2 MI versus type 1 MI, and to appreciate the importance of different investigations and really a comprehensive cardiac risk assessment. I'll start with a case which I think is fairly representative and something that I'm sure we've all seen before, but a 62-year-old gentleman presents to the emergency department with shortness of breath, fever, and a cough. This is just a completely made-up case, but I hope you guys can understand the flavor I'm going for. He's got a medical history of diabetes, hypertension, GERD, anxiety. He's on some basic medications for this. It's relatively well-controlled diabetes. He's on some amlodipine for his blood pressure, but there's really nothing crazy here. He is a lifelong non-smoker, really minimal alcohol intake. And again, there's no family history of premature coronary disease whatsoever. Overnight, he's admitted to the internal medicine service with a community-acquired pneumonia as the presumptive diagnosis. He's treated with some antibiotics. He's given some IV fluids. His initial presenting vitals, he's febrile, he's tachycardic, he's perhaps a little bit relatively hypotensive compared to where he normally sits. He's a little bit hypoxic, and so he's on a couple liters of oxygen. Otherwise, he's doing okay. When you speak with him, he says there's no symptoms whatsoever. There's no exertional chest discomfort. There's nothing ischemic sounding whatsoever. He has maybe some shortness of breath and some dyspnea. He has maybe some discomfort with coughing, but that's really about it. There is no heart failure syndrome symptoms or really anything else, and the review systems is unremarkable. His initial ECG, again, point is not to really belabor it, but just to say that it's essentially sinus tachycardia. There may be some borderline changes here or there, but really nothing that stands out. His initial investigations demonstrate a leukocytosis, and he has a chest x-ray which demonstrates a right lower lobe consolidation. So again, all of this in keeping, very much in keeping so with a community-acquired pneumonia, very straightforward. Now his high sensitivity troponin is mildly elevated at 150. So I guess my questions for the audience, and I'm not expecting an answer, but more for just people to consider, are, do you feel like this patient has had a myocardial infarction by definition? And if so, what type of MI? Do you feel like the degree of troponin elevations around 150 or the delta troponin would influence your decision in this diagnosis? Can you give an estimate, or do you have an understanding of what this patient's future risk of cardiovascular events may be? And when the internal medicine team is asking you for recommendations, are there any additional tests you would recommend at this time? Is there anything that could be additionally helpful in assessing cardiovascular risk? These are some questions that if you can just keep in the back of your mind and maybe think about as we go through this presentation. I'm just curious to see what everyone's approach may be. Before we dive into all that, I think you need to define the clinical question, which it goes back to the fourth universal definition of MI back from 2018. And so this definition, and again, this is probably quite basic for most in the audience, But essentially, myocardial injury is defined as elevated troponin greater than the 99th percentile of the upper reference limit for age and sex specific cohorts. And it is considered an acute myocardial injury if there is a change, either rise or fall, of the cardiac troponin values, with at least one of these being above that limit. It would be considered what was denounced as chronic myocardial injury if there is not really a change or fall. And the additional myocardial infarction really is the presence of myocardial injury with clinical evidence of acute myocardial ischemia. And what that really entails, looking through it all, it's relatively vague, but essentially symptoms that are concerning for myocardial ischemia, ischemic ECG changes, obviously identification of a thrombus on cath or other kind of coronary imaging, and imaging evidence of loss of myocardium or wall motion abnormalities. So wall motion really on echocardiogram. From here, the general schematic and discussion that I'd like to just go through for a brief second is that once you've identified myocardial injury, and once you've identified that it's acute, you can look along the left side and notice that if you believe there to be acute ischemia, then you have diagnosed acute myocardial infarction. And in this scenario, you are deciding really between type 1 and type 2. Now, obviously, there's type 3 to 5 MIs. I'm not going to get into that for the purpose of this talk today. It's really kind of beyond and would be overly redundant. But type 1 would be defined as your classic atherosclerotic plaque rupture. The pathophysiology is directly related to thrombosis formation within the coronary vasculature itself. And type 2 is acute ischemia in the context of an oxygen supply and demand imbalance. So there is decreased supply for whatever reason or increased demand for whatever reason. Separately, if there is no acute ischemia, you would just call this acute myocardial injury. And separately, if there was no dynamic changes in the troponin, you would call this a chronic myocardial injury. The way to conceptualize type 2 myocardial infarctions as well as etiologies of this, there's so many different things which may cause a supply-demand mismatch. There's a big long list over here. One conceptual framework that I found somewhat helpful is just dividing it into big buckets of either cardiac causes, systemic, and coronary. And to be clear, these causes are not necessarily independent of each other, but multiple can be present at the same time. And indeed, oftentimes, multiple of these different etiologies are present at the same time to create this myocardial oxygen supply imbalance. So in terms of cardiac causes, you can think of arrhythmias, both tachyarrhythmias and bradyarrhythmias, heart failure, Takotsubo's cardiomyopathy. From systemic causes, these are your classic sepsis, stroke picture, anemia, or severe hypertension. And in coronary causes, interestingly, this would be kind of your Minoka looking etiologies. So this is your SCAD or your vasospasm or your coronary emboli, as these are technically coronary causes of demand ischemia of myocardial imbalance, however, not related to plaque erosion, rupture, and thrombosis formation within the coronary artery itself. As you can probably imagine, it is a bit of a diagnostic dilemma. And although we have a tendency, and you'll see in a lot of clinical notes, people say the word and use the word type 2 MI very frequently, but maybe oftentimes this is applied incorrectly. And so looking through the literature, this paper over here looked at 50,000 patients with suspected MI and high sensitivity troponins available. And when retrospectively reviewing these charts, they took a few trained reviewers and they compared the diagnosis of the trained reviewers with the discharge summary diagnoses. What they found really was that, again, this was in Scotland and Sweden, that the proportion of type 1 MIs, people were relatively good at diagnosing type 1 MIs, although about 20% of type 1 MIs that were ultimately adjudicated to be type 1 MIs were not given that final diagnosis anywhere on the chart at discharge. But people are relatively bad at identifying type 2 MIs. Less than 20% of what was eventually adjudicated as a type 2 MI was actually even called a type 2 MI. This reflects kind of the broader literature, and that oftentimes physicians from all different specialties are not so great at identifying these clinical scenarios, and I'll tell you why that's important later on. Again, these are patients who are admitted to hospital but may have been admitted to any other kind of service, neurology, internal medicine, etc. What about when you take trained reviewers? So these are cardiologists at Swedish hospitals, and they were specifically looking through and seeing whether or not they could even agree on the type of MI there was. And in this study, there's about 1,300 patients at 8 Swedish hospitals. And with these two trained adjudicators, there was still a significant discrepancy between what was adjudicated ultimately as type 1 or type 2 MI. The Kaplan coefficient was only 0.55, and the overall agreement was only about 77%. Again, just emphasizing the fact that there's so much overlap with some of these definitions and so much clinical uncertainty that sometimes, even when you are a trained cardiologist, you may disagree. Are troponins helpful in making this distinction? I've heard from a lot of different people that they are. The actual literature supports this to an extent. In a wider review of the literature and a few different cohorts, what we can see here is peak troponin I concentrations in type 1, type 2, as well as myocardial injuries. And what you'll notice here is that in general, the median peak troponin I concentration with type 1 MI is higher than type 2 MI or myocardial injury. However, the interquartile ranges often overlap quite a bit, as you can see over here. What about the delta troponin? In this study over here, there was about 1,200 patients who presented to a single emergency department, all comers with serial troponins for symptoms of ischemia. Ultimately, about 207 were diagnosed with type 1 or type 2 MI. And the only thing I'll highlight here is that when they looked at the delta change over 6 hours with troponins, what they noticed was the receiver operating curve, like the area under the curve for the receiver operator characteristics, for the relative or absolute change was only about 0.5 or 0.6. Again, for discriminating between type 1 and type 2 MI. Again, suggesting that the ability of delta troponins to discriminate between type 1 and type 2 MI is not actually as good as we may think. In a separate study from a large study in Scotland, which I'll reference quite a bit, about 48,000 patients, again, similarly presenting to multiple EDs with suspected ACS and a troponin level. You can see over here, the peak troponins were kind of all over the place, to be quite honest, tending to be higher with patients with type 1 MI, but not 100% of the time. Moreover, the delta troponin change, while you notice that it is higher in patients with type 1 MI, and the relative troponin and the absolute troponin change is relatively higher with type 1 MI compared to type 2 or acute myocardial injury, the actual testing characteristics were not that great. When you combine presenting troponin with absolute change or absolute troponin with relative change, the area under the curve is actually only about 0.64 or 0.66. So again, these are not that helpful, and these kinetics are not that helpful or as helpful as we may be led to believe in differentiating between the two. Point of all this is just to highlight that it is absolutely a diagnostic dilemma and still challenging even for trained people and with all the fancy tests that we have available to us. I want to talk a little bit more about the epidemiology as well as the outcomes of type 2 MI. Before I do, I want to list some very important caveats because I know this will probably come up. Type 2 MI is an incredibly heterogeneous population. Your 30-year-old lady who has SCAD in the context of postpartum is going to be very different than your 75-year-old gentleman with CKD, diabetes, hypertension, multivessel disease who's having an MI in the context of sepsis. These are obviously very different and they will have different outcomes, and obviously that is going to be challenging to study. As I mentioned before, these definitions that are included in these studies, when we look at epidemiology and outcome, have changed over the years and have even changed a little bit. People are not necessarily exact or precise. You can often have overlap of type 1 and type 2 MI. For example, Takotsubo's cardiomyopathy in the context of an NSTEMI is entirely possible. And then the last thing just to mention is that as you'll see very shortly, the type 2 MI population tends to be more highly comorbid. These patients tend to be older, um, and there's competing risks. And so a lot of these outcomes which happen may be more attributable to other competing risks. But again, I'll get into that in just a second as well. So, how frequently do we see type 2 MI? If you were to ask me when I'm on call, I think probably like all the time, or at least it feels like all the time I'm getting consults for this. That being said, when we look at it in big scale studies, we see that roughly a fairly good majority, or a fairly significant proportion, I should say, are in fact diagnosed with type 2 MI. Ultimately, this is the same trial, so I won't belabor the point here, but about 10,000 or 11,000 out of that 48,000 patients population was diagnosed with myocardial injury. Of the 6,000 that were diagnosed with MI, about 1,000 of them had type 2 MIs. In a different trial, you looked at probably a proportion of 500 patients with MI, 350 had type 1 MI, roughly 369, and 119 had type 2 MI. So again, a fairly significant proportion. And in some populations, actually, for example, this trial, which looked at patients presenting as all comers to an emergency department in Minneapolis, there was actually more patients with type 2 MI and type 1 MI. So a lot of this depends on the clinical context, where you're going to find the different, if you're going to find more type 1 or type 2 MI. That being said, it is a common diagnosis and a common clinical entity that we encounter. When you look at a huge number of trials, you can see that again, because of the differing diagnostic criteria and the different, I should say, rigorous nature of some of these studies, there's a wide variety in the prevalence of type 2 MI. That being said, it is on average probably estimated to be between 20 to 40%. This matters because in type 2 MI, outcomes are poor. Clinical outcomes are poor. In this study over here, of the Sweetheart Registry, or registry analysis, I should say, it's about 60,000 patients with a discharge diagnosis of MI among all the Swedish hospitals, like 73 Swedish hospitals. So a very, very large data pool. Within this group, they classified a number as type 1 or type 2 MI, or type 3 to 5. Again, we're going to focus on type 1 and type 2 MI. I will say that they made a differentiation between type 1 Minoca versus type 2 Minoca. I'm not entirely sure what the differentiation was there, because you may argue that these could be combined. That being said, I will focus on the type 1 MI with coronary disease and type 2 MI with coronary disease diagnoses over here. To look at the baseline characteristics of these populations, you'll notice that on average, these type 2 MI patients compared to type 1 MI patients are older, as I mentioned. They are more comorbid, have more proportion of hypertension, dyslipidemia. They have more history of MI, heart failure, and previous revascularization. This is relatively unsurprising, I think, from all of our clinical experiences. Looking at mortality long term, and so this is something like 5 or 12 out to 1,200 days, so something like 3 to 4 years. In general, what you'll notice is that in patients with type 1 MI with coronary disease, the mortality over this period of time reaches upwards to 25% compared to type 1 MI, which is more hovering around 15%. So again, this is a common thing that we see in a lot of the literature, actually, is that type 1 MI typically has worse long-term outcomes than type 1. Not necessarily all that unusual or uncommon, considering we're talking about a more highly comorbid population. That being said, this is all-comer mortality, and we're going to look at cardiovascular mortality in just a second. So again, back to the Scottish trial, 48,000 patients. Their baseline characteristics, again, a little bit more similar, but again, tending towards slightly overall, a slightly more older and comorbid population with type 2 MI. And in this scenario, you can see they actually try to differentiate or delineate between myocardial infarction and cardiovascular death and non-cardiovascular death. Really unsurprisingly, you'll see that in patients with type 1 MI on the non-cardiovascular death side, they're not really all that different from non-myocardial injury, and that's more or less what we would expect. And the patients with type 2 MI or even acute or chronic myocardial injury without myocardial infarction, we can see that there's a much higher prevalence or incidence of death, of non-cardiovascular death. I guess the other interesting portion to say about this is myocardial infarction or cardiovascular death is actually, while it's highest in type 1 MI, it is not that far off from type 2 MI or myocardial injury without MI. Looking at it in a slightly different setup, when you just look at myocardial infarction and cardiovascular deaths, the overall hazard ratio for type 1 MI is 5.6 compared to in type 2 MI 3.5. The caveats here is that these populations are not the exact same, and this is a retrospective. This is done over. It is prospective, but it's done with many, many, many patients, and It's hard to control for all different confounding variables here when they. And I'll kind of go into that in just a second in another trial where they tried to control for it a little bit better. So again, this is a separate study in Scotland of about 2,000 patients. Again, type 2 MI patients tend to be older, sicker. I won't belabor the point there. But you see the same kind of pattern where long-term mortality is worsened in patients with type 2 MI and myocardial injury as opposed to type 1 MI. So this is survival here. Similarly, you see the separation of the curves. When you look at major adverse cardiovascular events, they're actually relatively similar, that risk, versus non-cardiovascular death, where type 1 and type 2 MI, type 2 MI and myocardial injury are significantly more significant or have a significantly higher prevalence than type 1 MI. When you try to adjust for age, sex, and other covariates here, though, patients with type 1 MI do demonstrate lower rates of MACE overall over a 5-year period compared to patients with type 1 MI, but the relative risk ratio is 0.74. So while probably type 2 MI portends a lower cardiovascular risk over a period of time compared to type 1 MI, it is not so much lower, even after controlling for all the possible, or not all the possible, but many different covariates. And indeed, when we look at many, many, many different trials and we look at mortality, again, how we define this will vary. But the blue bars over here, or the blue lines, represent type 2 MI versus the red, which represents the type 1 MI group. You will see that in a lot of trials, in most trials, as we go farther out, you'll see that type 2 MI typically portends a worse prognosis. Again, perhaps not all that unsurprising for a sicker and older population. That being said, I think it bears worth mentioning, just because a lot of the times we feel or we think of type 2 MI almost as a benign etiology, or an etiology that doesn't portend that much risk as compared to type 1 MI. Looking at cardiovascular mortality and all-cause mortality in type 2 MI, again, across a number of different studies, you see that probably on average, although there's varying definitions and very varying prevalences across all these studies, on average, there is probably still somewhere between a 5 to 45, 50% cardiovascular mortality, depending on how far out you are looking. And so these are patients who are at increased cardiovascular risk for sure. And in some ways, you may even argue that they are at higher risk than what is being shown here, mostly because they have to contend with all the other competing risks from their other all-cause mortality. For example, people passing away from cancer would limit, obviously, their ability to pass away from cardiovascular mortality. So there may be some bias there. So hopefully, after all of that, I have convinced you somewhat that type 2 MI is important. It is relevant. We see it quite frequently, and it portends a worse prognosis in general and significant cardiovascular risk. The challenge that I think a lot of us face is there's no real evidence to support any real management strategy. In general, if this is a supply and demand issue, the supply we typically cannot fix right away. And so, in general, acute management is focused on reducing whatever demand that there may be, whether this is treating sepsis or treating anemia or hypotension. There are some randomized controlled trials which are still currently enrolling, which are looking to see whether or not there could be a role for earlier invasive coronary investigations and interventions um, in type 2 MI in particular. Uh, Again, still waiting, but and with no data published yet, but again, an area of active investigation. The more interesting part of all that, though, is actually not the acute management for me, but it is what do we do with these patients who we have sitting in front of us as we're consulting on them, and what do we do about all this risk that we see here? Um, there was an interesting study which looked at the prognostic value of perfusion imaging in patients with type 2 myocardial infarction. And it looked at about 230 patients with MI who had myocardial perfusion imaging within 90 days of their event, with abnormal perfusion being defined as greater than 55% abnormal perfusion deficit of the LV. The results here were relatively interesting. The proportion of patients with type 2 MI who had abnormal perfusion was about 39%. For the people who are more up to date on nuclear and the perfusion imaging world and the stats, my understanding is that the real world data, typically most up to date, would suggest that on average your all comer populations are having abnormal MIBs around 8 to 10%. And so this is still quite significantly elevated from what you would have expected from kind of an all comer population. And interestingly, the proportion of patients with ischemia greater than 10%, which is really kind of that cutoff, that magic number that we often care about so much in nuclear imaging world, was actually about 15%. So that's not a small or trivial quantity or number of patients. In fact, when they looked at these patients again retrospectively and looked for survival as well as and kind of MACE outcomes, they actually noticed that in patients with abnormal perfusion, there was worsened survival, death or MI, a cumulative kind of outcome over a period of time. So again, these are important outcomes that are directly contributing to patient mortality and morbidity here. In a separate study, which looked at patients with essentially 93 patients with type 2 MI, and they looked just to see whether or not these patients would have any LV dysfunction or coronary abnormalities with either cath or MRI. And when they took these patients, they found that 93 of these patients had, out of 93 of these patients, sorry, 26 of them had established coronary disease, and about 3 had a diagnosis previously of heart failure. After these 93 patients were enrolled and underwent either cath or CT, 63 of them were diagnosed with established coronary artery disease. So, and 35 with non-obstructive coronary disease, but 28 with quite significant obstructive coronary disease defined as greater than 70% stenosis. Just to say that in this proportion of patients, just by investigating and looking for coronary disease, they found something like a 30 or 40% more coronary disease than they had previously known. And only about 18 actually had normal coronary imaging. Similarly, in the patients who had structural imaging after cardiac MRI and TTE, 32 out of 93 ended up being identified with any sort of LV dysfunction defined as an LVF less than 55%, with 17 of those being identified as having moderate to severe LV dysfunction. Again, only 3 prior to this had a diagnosis of heart failure. What was important here is of the 63 patients who were identified with coronary disease, 25 out of them ended up receiving new preventative therapies, whether this was aspirin or statin. And of the patients identified with LV dysfunction, 11 out of 32 of them ended up receiving new heart failure directed therapies. So again, this was a prospective trial which just took patients who there was no indication at that time of, or structural or coronary investigations and just thought to ask the question, what if we investigate these patients? What might we find? And it ended up being management and practice changing for quite a significant proportion of them. In a separate study, 50 inpatients in a single center, I believe this was in Boston actually, in type 2 MI, with patients with type 2 MI, they underwent coronary CT with FFR. This is really the big picture line here. And these 50 patients who underwent coronary CT with FFR, a relatively significant proportion of them, about 21 total, were identified with moderate stenoses. And actually, a relatively significant proportion of those, 8 out of 10, had severe stenoses. 3 of them had CTOs. And a lot of them actually end up having FFR positive lesions as well. And these, again, were patients diagnosed with type 2 MI. They noticed, similar to the previous study, that there was increased rates of aspirin prescription in patients who were subsequently identified with obstructive coronary disease, increased rates of prescriptions of P2Y12 inhibitors, and actually 7 out of 50 end up receiving coronary angiograms thereafter, and 4 out of 50 ended up being revascularized with PCI, and actually 1 received a CABG. So again, this is about 4 out of 50 of these patients with diagnosed type 2 MI. No other real indication to have coronary investigations ended up receiving being revascularized, just because people thought to ask the question: is there something there, or could there be something there? All this to say, where do we go from here? I've presented a perhaps barrage and battery of information. In general, and I really like this schematic over here, management of type 2 MI, in my opinion, and again, I'd love to hear everyone else's opinion on this, should start with the pretest probability of type 1 MI. It should be balanced with the competing risks. Oftentimes, these are in patients with non-cardiac other medical issues, surgical issues that are going on. And so it has to be balanced against whatever else is happening with them, whether this be like a bleed or a surgical thing or sepsis or stroke. And based off of that pretest probability and that risk, that competing risk, to make a decision about whether or not further investigations need to happen as an inpatient or even as an outpatient. The one argument that I will try to make, which again, I'm curious to see what other people will say, is that given the significant cardiovascular risk with type 2 MI, it would not be unreasonable for cardiologists to be more involved in patients who have identified type 2 MI and to pursue further cardiovascular investigations, again, as appropriate within that specific patient context. We'll never know if we don't look, is I guess what I'm trying to say. My major conclusions and take-home points here is that type 2 myocardial infarction is very heterogeneous. It's very frequently encountered, and it's really associated with a lot of cardiovascular and non-cardiovascular events. The definition of this type 2 versus type 1 versus myocardial injury, it often overlaps. It can be very challenging, but at a minimum, I think when patients present to hospital or are hospitalized and we identify type 2 MI or even myocardial injury, this is an opportunity for us as cardiologists to possibly investigate and modify cardiovascular risk. And then obviously that how we choose to investigate and modify that depends on pretest probability, all the competing risks, and what we have available with adjunctive tests and imaging. Again, in these scenarios, it would not be unreasonable to consider at a minimum a structural assessment with an echocardiogram and perhaps even functional assessments routinely with nuclear stress testing, as well as or coronary CT, for example. I do have a bonus section where I would talk about something else. However, I want to leave it here for just a second, show you the references, and just ask for any questions or discussions. If there's not much questions or discussions, there is one other thing that I could chat about, but I'm curious to see if anyone has any questions or discussion points about this.
That's great. Thanks very much, Andrew. Approximately how long is this additional kind of like part 2, so to speak?
I'm gonna say it's gonna be about 5 minutes, 5 to 7.5 minutes.
Yeah, I was actually thinking that, it might not be a bad idea because I think we are okay for time. It's only 12:40. So I think that, it might be a good idea if you, present the rest of it. And then, because some of the questions that might come up it's possible that's related to your part two, right? So it might
Yes.
be better if we save the questions till the end so that, people can ask questions related to the entire presentation. Is that okay?
Fantastic. I think that makes a lot of sense because I wouldn't be surprised if I had a question.
Thanks.
So
Can I
as
interrupt?
oh
Yeah.
yeah,
I don't know. I'm just gonna ask through your mic because I'm
sure.
close to you. I just have a question about some of the graphs you presented. I thought it was really interesting that for the non-cardiovascular death, for a couple of them, the people with myocardial injury, but not actually type 2 MI, had even worse outcomes. And I was trying to wrap my head around that, like, who are the people who are doing worse, even though, like, so both type 2 MI and myocardial injury both have trope elevations, hard to say how much. But presumably those people with the injury, like, they don't have the ECG changes, they don't have the echo findings or what have you. And so I was just thinking, like, I would have thought those would all be like negative prognostic signs, and yet they seem to be doing worse in some cases.
Yeah, it's a great question. I think a lot of that depends on what your definition of the acute myocardial injury and chronic myocardial injury is. And a lot of these studies, you'd really have to go through them with like a fine-tooth comb. And I did try. A lot of the chronic myocardial injuries are coming from our end-stage renal disease population. So patients with troponins who are chronically elevated around 50 or something like that. And some of the acute myocardial injuries without evidence of like infarction are coming from like a myocarditis and some other kind of populations. So these are still populations that you would expect to have relatively high morbidity and mortality and cardiovascular events, but are not necessarily captured. But yeah, again, I think it's just an overall reflection of just how comorbid these patients are. There is other kind of additional kind of interesting information, which I didn't choose to present just because I wasn't sure timing wise, but there is other studies that have looked at even just minimally elevated troponins, which are stable kind of in the 30s, 40s, or just barely above the upper limit of normal, and whether or not this portends further risk. And it seems that it does. That being said, again, it's it's tough to define these things. And I guess the other point about that is, could some of these patients with acute myocardial injury have been misclassified and maybe they actually had type 1 MI or type 2 MI or something like that? And that's entirely possible too.
Thank you.
I'm going to mention just one last kind of quick bonus thing, and this won't be too fast. This is a very realistic component, and this is why I decided to touch on this very briefly. Your same patient with community-acquired pneumonia received a non-contrast CT chest, and it found a bunch of random things, but also moderate coronary calcification. And so what do you do with that? Is that helpful? Is this useful whatsoever? Non-gated, non-contrast CT chest. For those who don't know, this is your non-gated visual assessment, and typically how it would be expected to be reported as if it's mild, moderate, or severe. In the radiological societies, their guidelines and the references would actually suggest that you should try to report coronary artery calcium visually or quantitatively, actually, on non-gated CTs if possible. We know now that there is relatively good concordance with calculating the Atkinson score on non-gated CT chest compared to cardiac CT. This is like a number of different studies, but the kappa coefficient tends to be quite high, anywhere between 0.89 to 0.97. But how does visual assessment do? Because oftentimes when we're getting CT chests at St. Michael's or at other places, we're not getting an Atkinson score, we're getting just visual assessment. This was one study that, just to present you some information, where they looked at qualitative coronary calcium burden, and then they did formal coronary CT just to see how it all calculated out. In general, what you'll notice is that the agreement is not so bad, actually. One thing just to note in particular, 24% of patients who ended up having a rule out, like no coronary calcium by visual assessment, ended up having some burden of coronary artery calcium. The reason why I mention that is because many people are using coronary artery calcium scores clinically as something to essentially reassure patients, the power of zero, so to speak. And that is something that cannot necessarily be applied, obviously, with these visual assessments. And the reason why I bring that up is because I've seen this used quite often in consult notes, where people say, "Well, there's no coronary calcium on the chest CT, therefore we're safe." When you looked at that same kind of group overall, the ability of visually identified moderate to severe coronary artery calcium to predict a coronary artery calcium score greater than 100 was actually not so bad. The positive predictive value was about 88%, so actually quite reasonable. And an interesting study as well, in about 5,700 patients at Stanford. These are patients without any clinical cardiovascular disease, no stroke or peripheral arterial disease. And they looked at all these patients who had a non-contrast CT chest for any indication consecutively across several years. Then they had the coronary artery calcium automatically calculated based on a machine learning algorithm. So it's quite interesting and kind of piggybacks on our previous couple of grand rounds on AI and deep learning within the cardiac space. It was a previously validated algorithm, and the big results are that in patients who had a coronary artery calcium greater than 100, as defined by this machine learning algorithm that calculated off of non-contrast coronary CTs, there was increased all-cause mortality, there was increased death, MI, and stroke, and need for revascularization as well. That is the end of the bonus section. Just to say that my final conclusion from this will be just to say that a visual assessment of coronary calcium is helpful, especially when it's moderate to severe, predicting a coronary artery calcium greater than 100. It is not helpful as a rule out, however, and certainly could be related to increased mortality, and therefore also presents an opportunity whereby we could modify future cardiovascular risk and mortality for patients. Just an additional data point. Now I'll go back and I'll open it up for questions, and I'm just interested to see what people think.
That's great. Thanks very much, Andrew, for a very comprehensive, nice review of a very common and important clinical problem. So.